diabetes and management. The drug used in diabetes, insulin, this we use for type 1. Okay, if the patient need insulin, the patient not have insulin in body, type 1. Yesterday we classify insulin into four types. One, rapid action, and second, short action, short action. It's intermediate, third one, intermediate, and fourth one, long acting. The four category of insulin we use. And rapid action was Lispro, Aspart, Glulicin. Lispro, Aspart, Gluli, Glulicin. In short action, regular human insulin. So regular insulin. Most commonly we use regular insulin. Okay? Intermediate isophosphine insulin, crystalline insulin, also known as NPH, and long action glargine, and detimer, glargine and detimer. Okay, these are types of insulin: rapid, short action, intermediate, and long action. So what are the uses of insulin? Insulin we use for any patient in need. For example, if you suffer from type 1 diabetes, we use for that person. Okay, insulin we use if diabetes in pregnancy. Okay, diabetic patient with pregnancy, we use insulin. Insulin we use if patient have type 2 diabetes but needs surgery. Yeah. So for that purpose, we again shift the type 2 patient already using drugs. Okay, before and after surgery. Before and after surgery for better control of glucose. Okay, we use for that purpose in pregnancy, before and after surgery. The type 2 patient using medication, okay, for diabetes, for sugar control. But if needs surgery, we must shift patient to insulin. And this insulin we use for the emergency situation. In emergency, what are the diabetes emergency? The emergency to control the sugar level, for example, in case of DKA. Diabetic ketoacidosis is a complication of type 1 diabetes, okay? And it can occur in late stages the type 2 diabetes. Another hyperosmolar, non-ketotic, hyperosmolar, hyper hyperosmolar non-ketotic coma, hyperosmolar non-ketotic coma. Okay, so also hyperglycemia here, also hyperglycemia. So hyperglycemia here, your sugar level nearly greater than 400. The sugar level 600. Oh, it's a very high level of sugar. Okay. In DKA also acidosis there. So we need rapid control of glucose here in emergency situation. So we use insulin. Which insulin we use here for DKA, for hyperosmolar non-ketotic coma? So we need to use rapid action or short action. Okay, not go for intermediate, not go for long action. Intermediate long acting these insulin, they work very slowly. Okay, they work very slowly, So we can't use in emergency situation. Understand? Diabetes emergency, DKAN, HONC, hyperosmolar non-ketotic coma is a complication of type 2, and this one is a complication of type 1. Okay, and if the now the uses here summarize uses type 1 if the patient with pregnancy having diabetes or pregnancy diabetes due to pregnancy in both situation if already diabetic and now she conceived and if we shift the patient to insulin we must use insulin. Okay, and before and after surgery the patient with diabetes needs surgery, so we if patient using medication, we shift on insulin. These two are emergency. In case of decay and hyperosmolar non-ketotic coma, we must use insulin. It's important here. Okay, in emergency situation, rapid and short action, rapid and short action. Okay. Number five, use. Another use of insulin we use for hyperkalemia. Also important thing, extra use of insulin. Insulin, what's the function of insulin regarding potassium? Insulin is a potassium in the ECF. Insulin shift this potassium into the cell. Okay, insulin move this potassium into the cell in the intercellular fluid. So if the outside the potassium value from 2.5, if you can change to 3.5, 3.5 to 4, it's a normal range. Okay, so if the potassium level is 5.5 or it's a hyperkalemia, it's a maximum limit exceed 4.5 for hyperkalemia, so we can use insulin too. Okay, for hyperkalemia is also a dangerous thing. Hyperkalemia, high potassium is cardiotoxic, so we also need management on urgent basis. Okay, for hyperkalemia, we also can use insulin. So what is the root of insulin? The insulin, how we use insulin? Insulin mostly we inject subcutaneous, yeah, subcutaneous injection. So mostly use subcutaneous. Can we take insulin orally? It's not possible orally. Okay, why not to take insulin orally? Because insulin, the most structured protein. Okay, the protein structure they dissolve by HCl. I can't use orally. Okay. Subcutaneous route, important route here. Sometimes in emergency situation, we also need intravenous. Okay. For diabetic patient, mostly they're using subcutaneous. At the site of injection, sometimes abdominal skin, sometimes thigh skin. Okay, we use for subcutaneous injection. And there, what happened? Because insulin doing what? Insulin causing lipogenesis. Lipogenesis. Okay, lipogenesis. So at the site of injection, what happened? Lipodystrophy. Some small mass-like structure form at the site of injection is known as lipodystrophy. Lipodystrophy. Okay, it's a one side effect, important side effect. Another side effect of insulin, these are drawbacks. These are the side effects. Okay, side effect. Side effect number one, lipodystrophy. Another side effect number two, hypersensitivity. Hypersensitivity. Okay. Side effect number three, hypoglycemia. Hypoglycemia. Okay. Hypoglycemia. Hypoglycemia. So because the insulin causing what? Lipogenesis. So insulin can cause weight gain. Okay. Weight gain. It's a rare side effect. It's a rare, not important one. The weight gain. Okay. The important side effect of insulin, lipodystrophy, hypoglycemia, and hypersensitivity. Understand? So it's about all about insulin. Insulin type, long acting, intermediate, short acting. Rapid action and short acting insulin, regular insulin on frequent interval, the diabetic patient they use after the meal, after after meal they inject some according to the how much the sugar level. Okay, according to how much sugar level they adjust the dose, they adjust the how many unit we need according to the sugar level. Okay, the BS checking the blood sugar level thrice a day, and then according to the sugar blood sugar level they adjust the dose. Okay, and this one, if the patient have morning hyperglycemia, morning or postprandial hyperglycemia, so this we mostly use at night. At night, okay, at night, NPH insulin. And this glargine, this the dose. This we can use in one day, 3 times, okay, along with meal, like with the breakfast, with the lunch, with the dinner, and this we mostly take at dinner with dinner at night, okay. And this glargine datimer, this once dose is only once dose for 24 hours. It's a very long acting. It's a long acting. This long acting can control blood sugar level for longer duration. Understand? It's a long acting. The frequently used insulin for diabetes, this one, okay, regular and also this NPH, these two insulin. Very rapid action and the short action, they also present in emergency for use of DKA for hyperosmolar non-ketotic coma. Okay, this all about insulin, the side effect, lipodystrophy, hypersensitivity, hypoglycemia. Okay, now we move on for type 2 diabetes patient. Type 2 diabetes patient, first you must advise exercise. Exercise and change lifestyle, okay? Not start medication directly, change lifestyle and exercise, otherwise exercise. The what investigation we can perform random blood glucose level. We can perform fasting blood glucose level. We can perform oral glucose tolerance test or GTT, oral glucose tolerance test. Okay, and this fasting is very important, and this one to diagnose this one. This random is just for screening. Random mean you can take any time a blood sample to check the blood glucose. Okay, the fasting, you have the dinner and full night nothing ate, and tomorrow morning blood sampling is known as fasting. And oral glucose tolerance test, if first the patient drink some sweet thing, sweet liquid. Then after 2 hours, we check the blood sugar. After 2 hours, okay, it's known as oral glucose tolerance test. Fasting and or these two tests are very important. Okay. Nowadays, more authentic one, we check HbA1c, glycosylated hemoglobin. Glycosylated hemoglobin. Okay, so check the level of this. If the level is a bit high, glycosylated. According to level of glycosylated hemoglobin, this one is confirmatory. You also can call it diagnostic test. This one, okay, HbA1c. When you want to start drugs, the first these tests just you sure about. You're not much sure about the patient have diabetes. You perform random blood glucose, perform fasting blood glucose, and perform oral glucose tolerance test. Oral glucose tolerance test and fasting a bit diagnostic, okay, but you want to confirm the patient really have diabetes, and you need to check the when you want to start the medication, you must check the HbA1c level. If HbA1c level is greater than normal, then you can come to medicine. Okay, so what are the drugs we use for type 2 diabetes? Yesterday I make the group of the drugs. These drugs are doing what? These drugs, some drugs they increase the release of insulin. Some drugs they improve the resistance. Okay. Some drugs they block the digestion in GIT. Some drugs they eliminate glucose from the kidney. Okay. There are four categories. Four categories. Okay. Now we classify what the groups here. First one, begonides. First one, begonite. In this family, begonite we're having metformin. Metformin. It's a first line gold standard drug. Metformin. And nowadays also another drug is present. Fenformin. Fenformin, metformin. Okay. Begonites, number one family. And the second one, glitazone. Glita, second group. Glitazone. Okay. Third group, sulfonylurea. 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 Third group. Okay. Begonides, glitazone, sulfonylurea. Sulfonylurea. Done. And next, sulfonylurea, maglitinides. Next one, maglitinides. Maglitinides. Number 4, maglitinide. Number 5, glycoprotein. Glycoprotein 1 analog. Analog. Glycoprotein 1 analog. Number 6, DPP4 inhibitor. DPP4 inhibitor. Okay. Glycoprotein 1 analog, DPP4 inhibitor. Number 6, done. Number 7, sodium dependent glucose transporter 2 inhibitor. This drug works in kidney. Inhibitor. Number 5, 6, 7. Here's number 8. Number 8 here. Number 8, glucosidase inhibitor. Glucose is for digestion, inhibit digestion. Glucosidase inhibitor. Oh, it's a big list for diabetes, drugs for diabetes, yeah? But don't worry, I will make it easy. Begonides, metformin. First, you guys need to understand how these drugs are working, okay? Don't worry about their names. You must know which group, how they're working. Begonide, this drug acts inside the liver, okay? This begonide family, metformin. This metformin doing what? Metformin improve the resistance. Metformin decrease the resistance. Insulin in type 2 diabetes, there was 2 problems. In type 2 diabetes, one issue, insulin was little, yeah, low insulin. And the second problem, insulin resistance. There are 2 problems. So we try to increase the insulin first, okay. We also try to improve the resistance. Beta cell, they produce little insulin, and the beta cell, they produce little insulin. The insulin produced by beta cell also not working properly on carbohydrates, okay. Insulin produced by beta cell also not working. So the here now 2 issue, one production issue, production also less, and the resistance problem. So metformin doing what? Metformin help to improve the resistance, okay, decrease this resistance. So it means the insulin now can work. Understand? Insulin now can work Most of the time in many patients, most of the time in many patients, this is our first line drug we use for diabetes. It's a first line. It's a first line. Understand? It's the first line. It improves insulin resistance. And this drug work inside one action improvement in resistance, another inside the liver. It is block gluconeogenesis. Gluconeogenesis. If you know about a bit about biochemistry here, how we produce glucose, what you need for glucose, this lactic acid, RBC, inside the RBC, inside the RBC, there's no mitochondria. Yeah, no mitochondria. So how the RBC is surviving? The glucose inside the RBC change to lactic acid. So inside the RBC. From the RBC, this lactic acid is coming out, okay? And then transfer to liver. Then transfer to liver. If you exercising, if you're walking, running, playing, what happen inside the muscle? Inside the muscle. If you're doing rapid action, okay? If you're doing any strenuous exercise, very hard exercise, so what happens? The muscle also produce lactic acid. Yeah. So this lactic acid also delivered to liver, and this delivery system known as this cycle known as Cori cycle. Which cycle? Cori cycle. This is a Cori cycle. Okay. What's a Cori cycle? It's a lactic acid delivery in the blood. It delivered to liver for production of glucose. Clear? So metformin inhibit this gluconeogenesis. Now let me know what happened in your body. This lactic acid. Understand? RBC is producing lactic acid. So the important side effect, never forget this side effect of metformin. Lactic acidosis, okay? Lactic acidosis. If any patient have liver disease, chances for lactic acidosis is more. If the patient have kidney problem, renal failure, so that time I'm not going to use metformin because the kidney disease causing acidosis, yeah, kidney disease increase acid in our body. So this drug also causing lactic acidosis. So that in renal failure, in liver failure, in liver disease, the metformin still we need to avoid in the liver failure. In liver disease, lactic acid, so it can precipitate this lactic acidosis, okay? And make aggravate this acidotic condition. So it's lactic acidosis, okay? Another side effect, nausea, vomiting. Nausea, vomiting. Understand? Nausea, vomiting. And this drug, this metformin also another beneficial effect of metformin. This metformin doing what? Because the patient is suffering from type 2 diabetes. Which diabetes? Type 2 diabetes, okay? So in type 2 diabetes, you have insulin, yeah? But that insulin is not working. Insulin is not working. The problem was resistance. On carbohydrate, insulin not working. In carbohydrate, insulin not working. You use metformin. So metformin disrupt the also lipid metabolism and help to lose the weight. Weight loss, okay? It's a very important effect of this weight loss. So this is the reason. If one person come to you having obesity, and that person also diabetic, from all these drugs, I will prefer Bedula. If any person have obesity, okay, if the person is already thin person, diabetes, not use metformin, person already very like the weight is little, okay, the weight loss already there, so it can aggravate the weight loss. So obesity plus diabetes, understand or not? Obesity plus diabetes, because metformin the side effect weight loss. So I can use this, okay? I can use this as a beneficial effect. Understand? So weight loss is a side effect, but you can use in obesity. If the person diabetic person also overweight, you can use metformin. Understand? The side effect nausea, vomiting. The side effect lactic acidosis. Done. And third side effect weight loss. This is all about your metformin. So when diabetic person come to you, you done every investigation, yeah? You done every investigation, fasting blood glucose, random blood glucose, oral glucose tolerance test. At last, for confirmation, HbA1c. Okay. Now the confirm diabetes is confirmed. You want to start medication. What will be your first option? The always the first option, the metformin. Mostly we start the medication from metformin. If the person is already overweight, then I must use metformin. Understand? Then I must use metformin because overweight person, metformin also helps to reduce the weight. Understand? Okay. Now next thing, glitazone, another sulfonylurea, another maglitide. What's the glitazone? Glitazone also work inside liver. Okay. This drug, glitazone, also work inside liver. Glitazone also work inside liver. How they working? They work. They have special receptor PPAR receptor. If you memorize the lipid system, lipid drug, fibrates. You know, gamma-fibrinosyl and fenofibrate. Fibrates. Fibrates were used for triacylglycerol. Okay, hyperlipidemia patient. That drug, that group also, but that group for lipid. Okay, but using the same receptor, PPAR receptor, PPAR receptor, peroxisomal proliferative activating receptor, PPAR receptor. Okay, PPAR receptor. This PPAR receptor, this used by glitazone, and change the genetic machinery, act on genes. And what happened inside the liver? Inside the liver, glucose production decrease. Yeah, glucose production. It's also block the. It's also block gluconeogenesis. Okay. Another thing, second effect, also help to improve the resistance. Okay, another drug for resistance. Okay, first one we use begonide, help to improve resistance, and the glitazone also help to improve resistance. Understand? So these two group, begonide and glitazone, they help to improve the resistance. Understand or not? Okay, clear. Begonide and glitazone, they help to decrease the resistance. Then insulin can work. Then insulin can work properly. Okay, insulin can work properly. In this group, we having the two medication here. Number one, rosiglitazone, rosiglitazone, pioglitazone, pioglitazone. Understand? Rosiglitazone, pioglitazone. And these drugs, how they working, they change the genetic machinery. Okay, they work also inside the liver. They change the genetic machinery. Okay, they block the production of new glucose. They inhibit the gluconeogenesis, and they also help to decrease the resistance. Understand? They also help to decrease the resistance. The side effect. What is the side effect? The side effect. Oh, this was causing here weight gain. Understand? It causing weight gain. Causing weight gain. Weight loss done by begonide. Okay. Weight gain. So you can use in thin person, I think. Yeah. Weight gain, not in obesity. Weight gain. Another side effect, heart failure. Another side effect, edema. Heart failure is very important here. Heart failure. If the patient diabetic have heart failure already, I'm not gonna use glitazone. Okay. Glitazone can cause heart failure. Understand? Weight gain, heart failure, edema. Weight gain, heart failure, and edema. They can increase the risk of MI. They can cause heart failure. Understand? They can cause heart failure. Weight gain, heart failure, and edema. The second group. So these two groups, they're doing what? They help to decrease the resistance. Yeah. So in type 2 diabetes, one problem was resistance and one problem was low insulin. Yeah. Now we're working on here. We try to decrease the resistance. Begonide and glucagon. Begonide we can prefer is a gold standard drug. The patient have overweight, with diabetes, your drug of choice, metformin. Okay, and if the patient have the kidney disease and the patient have liver disease, then you must take care because metformin causing what? Lactic acidosis. It can precipitate acidosis. You need to take care, okay, in case of kidney disease and liver disease. Okay, now move on. Sulfonyl urea, meglitinides, glycoprotein analog, DPP4. Oh, the four groups here. What are these drugs? They're doing what? These drugs, they're doing what? These drugs, they release the insulin. What they're doing? They release insulin. Understand? They're doing what? They increase the release of insulin. Increase the release of insulin. Understand? They release insulin. Four groups there. Okay? Four groups there. The first one now, move on. Sulfonyl urea. Sulfonyl urea and magnetite. Sulfonyl urea and magnetite, they both group, they working, the site of action is same. These are the potassium channel blocker, okay? Potassium blocker. Sulfonyl urea and maglitinides, sulfonyl urea and maglitinide. What are these? These are potassium blocker. These are potassium blocker. Clear or not? These are potassium blocker. And what are these drugs? Glycoprotein analog. The glycoprotein analog, the drug name incretin, drug name incretin. And this drug is doing what? Incretin doing what? Incretin increase insulin, okay, and decrease glucagon. Glucagon decrease and increase insulin release. What is a DPP4 inhibitor? This glycoprotein. This glycoprotein is produced from the intestine. Okay, produced from intestine. This glycoprotein help to increase the insulin. DPP4, this is the enzyme. This enzyme break this glycoprotein. Okay, break this glycoprotein. So if you inhibit this enzyme, then glycoprotein can stay for more longer duration. So in this family, we having gliptin. Later we talk about their name detail. Gliptin. Okay, gliptins. What they're doing, they inhibit the DPP4 enzyme, then glycoprotein stay for more longer duration and also help to release insulin. So it means this drug, gliptin, also doing what? Increase insulin release. Okay, and sulfonyl urea and maglitinides, they also increase insulin release. Let's restart the meeting. Okay.
Yes, sir.
Restart.